Hello. I hope I'm reaching you at my first Facebook Live sessions, and we're now live to audiences, hopefully in Queensland and northern New South Wales, to talk about some fertility topics. My name is Dr. Andrew Cary, and I'm a fertility specialist. I'm an obstetrician, I'm a gynecologist and a fertility specialist here on the Gold Coast. I work at Queensland Fertility Group on the Gold Coast, which some of you may be aware is in the Pindara Hospital precinct, and I've been working there for some time. This is my 28th year at Pindara precinct, and all of my work is there. I enjoy the work I do, and that work is in fertility work as well as pregnancy care and delivering lots of babies. So we're here today to discuss a very important part of my work as both a carer for pregnancy as well as a fertility specialist, and that's about the challenging and distressing topic of pregnancy loss or miscarriage. I prefer to use the word early pregnancy loss, even though the medical terminology is miscarriage. Sometimes miscarriage can seem a little harsh. So sessions like these of Facebook Live, I know, have become quite popular, but I'm thinking that they're probably going to become more popular, aren't they? Now that we have the COVID-19 pandemic. This is a side product where we have Zoom meetings, we have Zoom gatherings, we even have Zoom dinner parties, and now a lot of our presentations to you, our important audience, is going to be electronic, and that's exciting. We can extend to a much larger field, but we have to get used to, like we do with our Zoom medical meetings and our Zoom hospital meetings, talking to the computer and having a number of you respond. I hope you're all safe. And please, in this COVID-19 pandemic times, enjoy the quality time you can spend with family, but make sure that you do exercise sensible safety precautions, keep safe distancing, keep careful hygiene practices, hand hygiene, and particularly looking after yourselves and your family. So as we go into tonight's topic of, as I stated, miscarriage or early pregnancy loss, it's worth reflecting that a large number of women of fertile years will experience this somewhat tragic event, and some, unfortunately, on even a number of occasions. So it's probably a topic that is very familiar to what some of you have already experienced. So if we talk a little bit about some of the things you offer as we go through, and I see Julie there mentioning what treatments are available to avoid miscarriage occurring, and that stems from the fact that miscarriages are of their own quite a common event, and so we would love to be able to completely rule out any miscarriage ever occurring again for our patients, our fertility patients, but also those who spontaneously conceive easily. But unfortunately, it is such a common event, and there is various statistics of between 10 and 30% of pregnancies will be lost in the early stage, typically the first trimester, treating early pregnancy loss or trying to prevent early pregnancy loss is somewhat challenging. We certainly do have some very fantastic technology. It's worth having an assessment if somebody has had a loss to work out why that might be. Sometimes that's due to chromosome abnormality of the pregnancy. In fact, a lot of the time it is. These are sporadic or spontaneous events. Sometimes it's due to a abnormality of the uterus, and sometimes it's due to some biochemistry changes, such as thyroid function or thyroid dysfunction, or there are also the circumstances of diabetes. So there's a number of reasons why, so treatment doesn't mean one treatment will suit all. And Haley is asking a question there: at what week can a miscarriage possibly be prevented once identified as starting? Haley, the awkward scenario is that typically when a person presents with symptoms that then go on to show that a miscarriage is occurring, there are very important things that we can do medically to assist, but we're not going to be preventing it. The diagnosis of early pregnancy is made by that first pregnancy hormone test, and I encourage all of my fertility patients, and in fact all of my patients that I care for who can even spontaneously conceive very easily, when they're having their pregnancy test diagnosed, to also have their progesterone measured, and then probably having that repeated somewhere between 3 and 7 days later to see there's the correct rise. So we see a rise in the HCG levels, and we see a good level, a plateauing level of the progesterone, and that's very reassuring. But then we can do an ultrasound, and our transvaginal ultrasounds are so accurate and sophisticated these days that it's not that long after you've found out you're pregnant that we can show the pregnancy in the womb, in the uterus. So we see a sac, we see a yolk sac, and we see a little teeny weeny little structure that may only be 5, even 6 or 7 millimeters in size, so less than a centimeter, with a strong heartbeat present. We can pick that up not long after the very commencement of 6 weeks. So 6 weeks, 3 days, 6 weeks, 4 days, 6 weeks, 5 days, we can confirm that the pregnancy is on its way. And obviously, the opposite is we can confirm that things aren't on their way, and then we can come up with medical solutions. So I hope that answers that question for you, Haley. But I've just got to scroll down to see what Crystal is asking there. Are there extra things we can be doing at home in regards to vitamins, etc., that can help with improving implantation? And that's a very good question, Crystal. The pregnancy losses that are often recurrent losses, particularly those who are going through fertility treatment, often what we refer to as implantation failures, where we know we've got a beautiful embryo and we put that embryo into the womb and it all seems fine hormonally and the endometrium is fine, but there's something preventing implantation. We really would like for there to be a very simple solution to what would improve what we call endometrial receptivity. And so that's where the lining of the womb will be able to encourage and accept the implanted embryo. But there's no specific vitamin that can help at the time. And there's a lot of research in this area. There's a lot of research going on the whole time. in trying to get that endometrial receptivity or implantation improved. And as yet, it's research and nothing coming out of it. So, but keeping healthy, Crystal, sorry, is a very important part of preconception and conception. So, minimizing alcohol intake, minimizing toxins to the body, such as cigarette smoking, and taking the preconception and periconception multivitamins, such as the high dose folic acid is important, but I would say there's no specific vitamin supplement that's going to improve implantation. Stacey has asked a question there about any advice on testing for recurrent miscarriages after seeing heartbeats 2 to 3 times. Yeah, so this, Stacey, is a very vexed area, and certainly once a person has had at least 2 and often 3 early pregnancy losses, it's very important to go looking for any cause that could give rise to recurrent losses. And so the important things to be looking for there are, is there any chromosome abnormality in either yourself or your partner? Because a chromosome change, such as what we call a balanced translocation, can mean that as an individual, I'll have the normal chromosome complement, but when I produce my sperm, or a woman produces her eggs, there can be unbalanced chromosomes, and that can give rise to a recurring cause of miscarriage. The shape of the uterus and the quality of the endometrium can also, so there can be septum, there can be adhesions within the uterus, there can be polyps or fibroids within the uterus that can cause problems. And the gold standard for looking at that is what we call a hysteroscopy. So that's looking with a telescope into the uterus. And then there's some blood tests, checking thyroid function, checking for some autoimmune conditions such as lupus anticoagulant, anticardiolipin antibodies. They're probably the main ones, but also even checking for long-term sugar control and diabetes. So I hope that's answered that question for you. And Alyssa has stated that she's been trying for a while and is 42 years of age. Unfortunately, Alyssa, probably this raises one of the most important problems that we have in our society, is that unfortunately most people are not having their babies in their teen years and early 20s. They're having their babies in their mid to late 30s or 40s, and unfortunately miscarriages does increase with age. And so the chance of an early pregnancy loss in the 20s is probably at the lowest, but then it rises by the mid-30s, and it particularly rises by the late 30s and early 40s. And so, but this doesn't mean that a pregnancy can't occur. It does increase the possibility that there are chromosome issues. And certainly one of the very advanced things that we can do in our fertility work, and this is possibly an option for you, Alyssa, but the specifics will need to be checked, is having IVF, where when we collect eggs and make embryos, we can then test those embryos. They can have what is called pre-implantation genetic testing, where the embryos can be tested for their chromosome complement. And a embryo that's tested at day 5 that has normal chromosomes has a much better chance of a successful outcome, because we know that whilst there are all sorts of reasons for miscarriages to occur, at least 40%, but a lot of the studies suggest even as high as 50 and 60% of miscarriages are due to an abnormal chromosome within the embryo. Penny's asking about acupuncture, and acupuncture is really, as Penny knows, Penny, it's nice to hear from you, knows that we can use acupuncture in our fertility treatment, and my very good friend Paige, who's an acupuncturist who works with us, offers a lot of women before and after they've had their embryo transfer with some acupuncture, and we know that that helps. We know that that helps relieve stress, and we certainly know that it's very useful in our adjuvant therapy in our fertility treatment. Paige believes that it helps improve the uterine flow, and I'm quite happy to encourage my patients to use acupuncture if they need to. How long does the process, how long approximately, Brooke's saying, does the whole process take from start to finish? Brooke, I presume you're meaning IVF. If we were doing an IVF cycle and doing pre-implantation genetic testing, I presume that's what Brooke might be asking me there. The whole process of starting a cycle and getting to the point where an embryo is tested takes around about 19 to 21 days. The thing that happens then, though, is that embryo gets tested, and all the embryos that are tested are then frozen while we await the result of the test to then start using the healthy normal chromosome embryos in a future cycle. And so that would be the next cycle in the next following month, and then a frozen embryo transfer of a healthy, what we call a normal chromosome embryo could be used. Chantel is asking, could a chromosome abnormality still be a possibility if you've had a successful pregnancy with the same partner? Chantel, the most important predictor of somebody being able to have a healthy pregnancy is that they've had a healthy pregnancy before. So that gives us a great hope that somebody is going to have healthy pregnancies. But even a couple where one of the couple has what we refer to as a balanced translocation will produce gametes, that's sperm or eggs, that have normal chromosomes and gametes that have abnormal chromosomes. And so even somebody who has a healthy child can then have another pregnancy where that's not the case. And yeah, Jessica is supporting the idea that Paige does a great job, and nice to hear from you too, Jessica. So I think that's, yeah, that gives some endorsement to adding acupuncture to your regimen. I've certainly used acupuncture for some minor ailments, and I find that it certainly relieves my stress, and I actually, Paige will note that I fall asleep in the acupuncture room. Crystal's wanting to know about MTHFR. MTHFR gene falls into the category of what we refer to as thrombophilias, and this is certainly a vexed area in investigating for recurring pregnancy loss, and we're kind of in an awkward scenario. The technology of everything we've done in our fertility work, and also the technology in what we've achieved in our pregnancy care is so fantastic, but we have this little area in between, which is our challenge, and it's the challenge all over the world in all areas dealing with fertility work and early pregnancy, is what is the key to improving that endometrial receptivity and implantation, and could there be something immunological, could there be something related to the clotting mechanism, so what we refer to as thrombophilias, Or could there be other factors such as natural killer cells that we just don't have the answer? And it's very important to know that this is being researched everywhere, and we are keen to get the solutions. We know a lot about what happens in the early stages of the embryo, but we have a gap when that embryo is placed in the uterus, and how things will develop, and how sometimes it implants and sometimes it doesn't. Sometimes the pregnancy gets to 6 weeks or 8 weeks or 9 weeks and then stops, and sometimes it doesn't. And areas such as the immunological areas, the thrombophilia areas, are not proven. And it is very important when you're doing a lot of your research and you're looking, that you must realize that all of those treatments that are offered are very much experimental, and they should be treated that way. They should be used in clinical trials. Now, the dilemma that you as an individual has is, have you got the time to wait the 5 or more years, maybe 10 years, who knows, for those solutions to come from good quality trials that are being conducted all over the world? Because at the current time, the use of things that might change the coagulation system, the use of things that might change the immunology of that interface between the embryo and the endometrium, the evidence is just not there, and should be considered to be experimental only. But thank you very much for that question there, Crystal. And and so these are all they're all very important questions that you're all asking, because a number of you have probably been through challenging scenarios, and I'm pleased to say that a number of the names that have popped up there have also had great successes, and so we promise you that we are working really hard, both in our fertility work and then on the other side with my obstetric work, in making sure that we kick a goal every time and have a healthy pregnancy as quick as we can for you, whether that's spontaneous conception, whether that's with some of our minor forms of assisted reproduction, or whether that's when people are needing to proceed to treatments such as IVF, and then even the pre-implantation genetic testing that I described, that is certainly another level up in terms of what sort of treatments we can offer people. So we'll move on there and see what Penny is saying there on thoughts on collecting lots of eggs. Is it a good idea to collect 15, 20 or even more? That's a good question, Penny. No, it isn't. When IVF started, and there still are parts of the world that do this, the chances of each egg fertilizing wasn't too good. That's number one. Number two, when the eggs fertilized to become embryos, how did they go on to grow? And were they suitable for freezing, and did they freeze well, and were they able to be used? Now, that's when, in the beginning phases of IVF, back decades ago now, 15, 20 or even more eggs were collected to make embryos to give a good, reliable outcome. Nowadays, because IVF is so much more successful, the science is so much more advanced, that we can collect much less eggs, 4, 5, 6, 8 eggs, and have excellent quality embryos, and have still embryos once we've transferred left to freeze, and then an excellent outcome after that. And the risk of collecting 20 or more eggs is that we're going to create a condition called hyperstimulation, and that has biochemical and hormonal risks to the patient. And so it's not good medicine to collect 20, 30 or more eggs. It is ideal to have somewhere less than 12. Elsa asks, Alyssa, sorry, trying to get pregnant, yeah, and down to the pregnancy test. So, yeah, Alyssa, obviously, I hope that you may be able to seek some help from a fertility specialist if you've been trying for some time now. And I suggest that Alyssa may well need to get a referral, see her GP and get a referral to see a fertility specialist, because I would love to say there is no hurry here, Alyssa, but time is not your friend, and there's various tests that we can do to try and work out what it is we can do to help you with. So Erin had a good comment there to say it had 7 failed transfers, and no pregnancy went further than 6 weeks. So Erin, that's a very awkward and distressing scenario. I see that you have mentioned that there's a condition called Asherman syndrome, and that's where there's scarring of the uterus, the scarring of the lining of the uterus, and often the lining of the uterus is quite disjointed, doesn't build up in thickness, and your lining, you said, got to 7 to 8 millimeters before transfer. Well, 8 millimeters is quite an adequate lining, but if there is scarring of the endometrium from Asherman syndrome, that needs to be assessed by a gynecologist that has the expertise in doing hysteroscopic work to help there. There is some research going on, and even looking at trying to inject platelet-rich plasma, or PRP, into the endometrium to see if that can grow. There's all sorts of research, but once again, they're on a trial basis. But there is certainly hysteroscopic or surgical procedures that we can do to improve the endometrium and take away some of the scarring. And it's nice to hear from Fiona there and Penny. So thank you very much. And you're welcome, Fiona. I hope you're going well, and I hope parenthood is looking after you and treating you kind, particularly in these challenging times when we're all locked down. But what a great way to be locked down, but with a recently born baby. So Erin, I would say, I feel very sorry for you that the pregnancies haven't advanced very far, but as you rightly said, if you've had that many failed treatment cycles, it's very understandable why it comes down to taking some pretty brave approaches in terms of trying things like the immune protocol that you said. So there are times when fertility specialists will advise people to go on corticosteroids, which is prednisone or prednisolone, not uncommonly combined with low-dose aspirin, or what you will hear about being called baby aspirin. And then sometimes the addition of extra progesterone as well, in an attempt to provide that answer, because unfortunately, whilst the research is so critical and it's so important because we must do what is safe, there are some people who clearly can't wait the many years that might be necessary to provide this answer. So when I've retired, there hopefully will be an answer for endometrial receptivity issues. But right now, I wish I could answer how we're going to solve that, but there's certainly plenty of trials going on. So we've got to the 30-minute mark, and I don't want to bore you all with hearing me prattle on, but I hope tonight's discussion about a very important topic of early pregnancy loss is been useful to you. I hope I've been able to touch on some of the questions that you have. And if this has brought up further questions or further statements, then please feel free to contact our 1-800 number at Queensland Fertility Group. I work at Queensland Fertility Group Gold Coast and Queensland Fertility Group throughout the state of Queensland is there to help our women wherever you are located. And the 1-800 number is a great resource, and the women who man that will put you in touch with the right sort of people. Okay, and it is great to hear from a number of my small group of fans there, and thank you, Penny. I won't retire. I'm here for the long haul, and I enjoy my job, and you know that. So look, it's been wonderful to speak to you all, and I hope this has been somewhat useful to you. So good evening, and as I said at the beginning, stay safe in these COVID-19 times, and look after yourselves, look after your family. And it's been great to talk to you. Good night.